Uh, I'd like to invite Dr. Rania Mogawer. She's going to speak on value of adding platelet-rich plasma to non-cultured epidermal cell suspension in surgical treatment of stable vitiligo. Over to you.
Thank you. My talk is about the value of adding platelet-rich plasma to non-cultured epidermal cellular suspension in the surgical treatment of resistant vitiligo. This was a self-controlled, randomized, double-blinded study. As you all know, acral vitiligo, followed by the vitiligo overlying joints, are quite resistant to different modalities of treatment, including the surgical treatment. And platelet-rich plasma has been reported to enhance the repigmentation of different therapeutic modalities of vitiligo, including the vitiligo surgery. And thus, we aimed at evaluating the role of suspending the non-cultured epidermal cellular suspension in PRP in cases of acral vitiligo and resistant vitiligo lesions overlying the joints. Knowing the resistance nature of these lesions, we tried to optimize our results using a low expansion ratio of 1 donor skin to 3 recipient area, and we added the PRP as an optimizing tool to the melanocyte pellet on one side, while on the other lesion we added lactated ringer. We gave our patients thrice weekly excimer laser sessions for a duration of 3 months. This was a randomized, self-controlled, double-blinded clinical trial that included non-segmental vitiligo cases having either 2 comparable acral lesions, either symmetrical or in the same anatomical area, or vitiligo lesions overlying the joints that were resistant to the medical treatment. We excluded segmental vitiligo, as well as any patients who received any topical or systemic treatment in the past 3 months. Before doing the surgery, we evaluated the baseline platelet count for our patients, the baseline surface area using the point counting technique, as well as lesional pigmentation using the VESTA score. The non-cultured epidermal cellular suspension was done by harvesting the donor skin via a tear graft, followed by putting it in the trypsin in the incubator at 37 degrees Celsius for 40 minutes, after which the suspension was prepared and centrifuged, getting a melanocyte pellet. The melanocyte pellet was suspended on one side in the PRP and on the other side in lactated ringer. The recipient site was prepared using carbon dioxide laser resurfacing. All the steps were repeated twice for 2 comparable patches using a low expansion ratio of 1 to 3. After complete healing, the patients were given excimer light sessions for thrice weekly for a total duration of 3 months. At 8 weeks, preliminary assessment was done using the VESTA score, as well as physician global assessment. At 3 months, the patients were evaluated for the surface area of the lesions following surgery using point counting, lesional pigmentation using the VESTA score, physician global assessment, patient satisfaction, and color match. We evaluated 30 patients, 17 met the inclusion criteria, and 15 only completed the study. Most of the patients were having acral vitiligo overlying the feet. Regarding the pre-procedural assessment, there was no significant difference between the PRP suspended non-cultured epidermal suspension and the ringer lactate suspended non-cultured epidermal suspension regarding the baseline VESTA score and surface area of the lesions prior to the surgery. At 8 weeks, on both the PRP and the ringer lactate site, the VESTA score increased significantly in comparison to the baseline before the surgery. However, there was no difference between the PRP suspended non-cultured epidermal suspension and the ringer lactate suspended non-cultured epidermal suspension regarding the lesional pigmentation following surgery. At 3 months, we evaluated the patients using the physician global assessment. Half of the patients had accent-free pigmentation, and on both sides, the VESTA score significantly increased after non-cultured epidermal suspension in comparison to the values prior to the surgery. Similarly, the surface area significantly decreased on both the PRP suspended non-cultured epidermal suspension site and the ringer lactate suspended non-cultured epidermal suspension. However, on comparing both sites together, there was no difference regarding the lesional pigmentation as per the VESTA score, the surface area of the lesions as regards the point counting, the physician global assessment, as well as the patient satisfaction and the color match. Different disease characteristics and the baseline Vesta score and the platelet count were not of influence on the change in the surface area as well as the change in pigmentation. Here are examples of our patients. This patient showed good repigmentation at 8 weeks and excellent repigmentation at 3 months with no difference between both sides. This patient showed moderate repigmentation with no difference between both sides. And this patient showed mild repigmentation with no difference between the PRP and the lactated drink. So, despite previous promising studies on the PRP in vitiligo surgery, none of the conducted studies were selecting only resistant acral lesions and lesions overlying the joints. In addition, some of the studies included both segmental and non-segmental vitiligo, and they evidently differ in the response to vitiligo surgery. In addition, our study was a self-controlled study. So, despite trying to optimize our surgical technique using a low expansion ratio, giving the patient excimer light sessions for 3 months, suspending the melanocyte pellet and PRP did not prove to be of value in the surgical treatment of acrovitiligo and vitiligo overlying joints. So PRP offered no privilege in surgical treatment of acrovitiligo and vitiligo overlying the joints, which are quite resistant to treatment. A kind reminder for the VIS, and we'll be happy to welcome you in Egypt, and thank you.